Perioperative physiologic monitoring provides clinical data critical to assessment and maintenance of cardiac, respiratory, neurologic, and renal function during and after any open or endovascular procedure. Basic intravenous access monitoring, and all patients should have at least one sizable 16 or 18 gauge intravenous line, as well as the ECG, temperature, and blood pressure monitoring apparatus. A urinary catheter and collection system to measure urine output may be needed for operations that last longer than a few hours or endovascular interventions that require the patient to remain supine for several hours post-procedure. Pulse oximeters are necessary and are required and are recommended, and the placement of an additional pulse oximeter probe on another site in these instances is recommended. So there should be one pulse oximeter at a central location and another pulse oximeter at the involved limb that is the target for revascularization. Arterial and central venous access is more significant for open vascular operations or in cases in which the patient's blood pressure can be expected to be labile. The arterial line allows easier blood sampling for repeated measurements of arterial blood gas, hematocrit, electrolytes, and glucose, as well as continuous blood pressure tracings. The central venous line allows measurement of central venous pressure and infusion of resuscitative fluids and medications at a more brisk rate, depending upon the size of the catheter or sheath. Core temperature monitoring is important for open aortic or extremity vascular cases that last for more than 2 to 3 hours. Hypothermia is associated with risk for cardiac events, including ventricular tachycardia related to elevated levels of circulating catecholamines. In addition, hypothermia contributes to coagulopathy by adversely affecting the enzymes that participate in the clotting cascade. Esophageal, intravenous, or bladder temperature monitors are all generally acceptable and accurate. Warming the operating rooms to 75 degrees Fahrenheit before the patient enters and using warm air plastic drapes like the bear hugger are helpful measures to maintain the patient's core temperature. Transesophageal echocardiography, or TEE, is another option for monitoring cardiac function in the operating room. TEE is a sensitive method to detect myocardial ischemia, manifest by the development of myocardial wall motion abnormalities, and can accurately assess left ventricular filling and function, for example, the ejection fraction. With regards to pulmonary capillary wedge pressure measured by the Swan-Ganz pulmonary artery catheter, despite the physiologic information that this technology provides, the value of using a PA catheters is debatable, as some prospective studies have shown that their use does not really improve mortality. Now, once the final timeout or operating room briefing has occurred, final patient positioning and setup can take place. Special attention should be paid to whether or not to tuck the patient's arms next to his or her side of the table and whether any fluoroscopic imaging equipment, for example, the C-arm or wall-mounted imaging arm, or even the ultrasound machine, will be positioned during the procedure. Again, anticipation and planning before the final procedure and the final preparation and draping are important for a safe, effective, and efficient procedure. In addition to positioning for proper retraction and or fluoroscopic imaging, patient positioning has been shown to be critical in avoiding patient pressure-related injuries to the skin and the peripheral nerves. The most common pressure-related problems have been the lateral heel and the malleolar ulcers. These ulcers are multifactorial and often occur in patients with lower extremity ischemia who undergo longer duration procedures. Pressure-related heel ulcers can be prevented by elevating the legs on soft towels so that the heels do not rest directly on the operating table, or by placing soft egg crate padding under the heels themselves. Attention should also be paid to the lateral leg to ensure no undue pressure over the fibular head, leading to peroneal neuropraxia. Another potential problem occurs when the upper extremities are tucked along the sides of the patient, and pressure from the edge of the operating table compresses the ulnar nerve, causing a neuropraxia. This bothersome problem can be prevented by gently wrapping the elbow region with soft egg crate pads to protect the ulnar nerve. Now, lower extremity reconstructions, arterial reconstructions, can be performed using either general anesthesia or regional anesthesia or mixed general and regional anesthesia. Simple local anesthesia with sedation may also be used for percutaneous lower extremity interventions. The choice really depends upon whether the case is open or endovascular, patient comorbidities, and anesthesia and surgeon presence, experience, and preference. The indication and appropriateness of regional technique should be decided by anesthesia team on consultation with the vascular providers. The surgeon should provide input on the choice of anesthetic and its potential ramifications. The individual patient's acceptance of and ability to safely have a regional anesthesia must be considered. Factors such as dementia, risk of pulmonary aspiration, and previous back or spinal injury may decrease the advisability of a regional technique. The use of regional anesthesia in patients receiving anticoagulation or antiplatelet therapy remains unsettled, and decisions are often based on an individual patient situation. Although most studies reveal low complication rates of epidural anesthesia placed in association with patients on antiplatelet therapy or patients on low molecular weight heparin, the risk is not zero. Because bleeding complications in this setting can lead to significant morbidity, we defer to our anesthesia colleagues on a case-to-case studies or a case-to-case basis as to which patients are candidates for epidural anesthesia. Once an epidural catheter is in place, the same expertise is needed to determine the need to hold antiplatelet or anticoagulation medications before and around the time of catheter removal. Improved anesthetic management has been the key factor in the reduction of perioperative morbidity and mortality in vascular and endovascular surgery. The preoperative assessment of the patient and his or her comorbidities form the basis of selecting the most appropriate anesthetic. The anesthesia team must be aware of the planned procedure and its conduct. The type and the depth of anesthetic varies widely among the range of vascular and endovascular procedures to be performed. Therefore, for the smooth conduct of any vascular or endovascular operation, regardless of the level of complexity, communication between the vascular and anesthesia providers must begin before the start of the case and continue all throughout. A few words on fluid replacement. Throughout the aortic revascularization procedures, adequate amounts of fluids, usually crystalloids, such as normal saline or Ringer's lactate, should be given. Fluid replacement should be guided by indices of ventricular filling, maintenance of good cardiac index, and adequate urine output of at least 0.5 cc per kilogram per hour. It is not uncommon for crystalloids to be administered at rates of 750 to 1,000 ml per hour during open aortic procedures due to evaporative fluid loss from exposed bowel and associated blood loss. Because patients are prone to becoming hypothermic during long operations, crystalloids and blood products should be warmed as they are infused. In addition, hypothermia can be prevented by using a heating tent and by increasing operating room temperature. Some notes also on unexplained hypotension during aortic surgery. This must be met with a certain calm and rapid assessment of the patient for possible causes, for immediate correction if necessary. Palpation of the aorta or transduction of the femoral sheath pressure should be performed to confirm the anesthesia monitor's initial indication. If there is a strong aortic pulse or normal pressure is transduced through the femoral access sheets, attention should be focused on probably fixing something on the monitoring system. Probably there might be a compression or occlusion of the arterial line. Bleeding from endovascular access vessels can also occur during placement of the device sheets through the iliac vessels and even at the aortic bifurcation. The diagnosis of iliac or aortic perforation can be accomplished by performing flush aortography or retrograde angiography through the femoral sheets. If there is high suspicion that perforation of an access vessel is responsible for hypotension, a compliant balloon and covered stent should be quickly readied on the back table as the diagnostic maneuvers are performed. Myocardial ischemia, myocardial infarction, or arrhythmia can be found by findings on ECG or TEE. Tension pneumothorax resulting from preoperative central venous line placement will be accompanied by distended neck veins and a high airway pressure shown on an anesthesia machine's ventilator. Cardiac tamponade from right atrial injury during preoperative line placement will also be accompanied by distended neck veins but more normal airway pressures initially. Malignant hyperthermia is a rare but serious complication accompanied by increases in end-tidal CO2 and in the patient's core temperature. It may also be accompanied by mixed acidosis, increased oxygen consumption with rhabdomyolysis. Manipulation or withdrawal of the intestines from the abdomen during open aortic surgery may also cause hypotension, which usually can be corrected with a fluid bolus. And the blood pressure may also decrease when the inferior vena cava is being compressed or retracted, secondary to decreased venous return to the heart. The surgeon must inform the anesthesia team prior to performing this maneuver. Now, one of the most stressful steps for myocardium during aortic operations is occluding the aorta with a vascular clamp during open operations, or with an endovascular balloon during endovascular procedures. This maneuver acutely increases left ventricular afterload and strain and cause supranormal pressures in the aortic arch and cerebral circulation. Aortic occlusion, whether from a clamp or an endovascular balloon, increases blood pressure and pulmonary capillary wedge pressure, which may result in ST segment changes or ventricular irritability on the ECG monitor. The healthy heart can tolerate these changes. However, the diseased heart is at high risk. In the case of a severely impaired heart, the blood pressure and the cardiac output may actually decrease with placement of aortic occlusion. In such cases, and in an apparent paradoxical step or a counterintuitive step, titration of the peripheral vasodilators is necessary to reduce afterload acutely. Inotropic support should also be added if necessary to stabilize the hemodynamics. For these reasons, it is imperative that the surgery and anesthesia teams communicate regarding the timing and positioning of the aortic cross clamp or the balloon and its release. Now, with aortic occlusion, renal blood flow and urine output is also likely to decrease even if the aortic clamp is placed below the renal arteries. This effect can usually and can often be mitigated by establishing a diuresis before the aortic occlusion using hydration and, on occasion, administration of intravenous mannitol of about 12.5 to 25 grams. The preoperative central venous and pulmonary wedge pressures, if it is attached, and left ventricular function should also be continued and considered to confirm the patient is adequately hydrated prior to initiating this type of a diuresis. If mannitol is not effective, 10 to 20 milligrams of furosemide may also be given, although this decision should be discussed between the surgery and anesthesia teams before giving the medication. During any diuresis, Potassium and other electrolyte levels must be carefully monitored and supplemented to prevent arrhythmias that may result from their depletion. With aortic clamping, so much so with aortic unclamping. It is likewise one of the most critical times of an aortic operation with the release of an aortic clamp or the deflation of an aortic occlusion balloon. The maneuver rapidly decreases cardiac afterload and can lead to profound hypotension. The surgeon should prepare the anesthesia team several minutes before unclamping or several minutes before deflation of the aortic balloon. The aortic occlusion should be released slowly while the surgeon views the arterial blood pressure tracing. If significant hypotension occurs, the clamp can be partially or completely reapplied or the compliant balloon reinflated while resuscitation is achieved. Hypotension can be minimized by intravascular volume loading, avoidance of myocardial depressants and vasodilators, as well as inhalational anesthetic agents prior to clamp release or balloon deflation. In some cases, small amounts of sodium bicarb will be beneficial. And we generally give intravenous calcium chloride also, which increases myocardial contractility and blood pressure. If one reverses heparin with protamine at the end of the unclamping procedure, it must also be administered slowly as it can cause hypotension and or bradycardia. In rare cases, protamine may also lead to severe bronchospasm and hemodynamic instability. Some considerations in post-operative care. Despite multiple medical problems and sometimes extensive operations, most patients who undergo aortic or lower extremity arterial reconstructions for occlusive disease can expect a reasonably uncomplicated recovery if certain principles of care are followed. Initial stabilization after aortic reconstructions should be done in an intensive care or step-down setting where vital signs, urine output, ECG, rhythm, and respiratory status can be monitored continuously for 12 to 24 hours. On arrival to the recovery area, the patient's blood pressure, heart rate, and rhythm should be checked, and ABGs are drawn for analysis. If the patient is intubated, ventilator settings should be adjusted after review of the initial blood gases. A plan for extubation should be established. After these vital functions have been stabilized, additional baseline tests may be obtained, including a portable chest X-ray, to check endotracheal tube position and to ensure adequate lung expansion. In addition, a formal 12-lead ECG should be compared with the preoperative ECG for any evidence of myocardial ischemia or rhythm changes. Cardiac enzymes should be sent only if intraoperative myocardial ischemia or arrhythmia was detected. However, in general, routine cardiac enzymes at the ICU or at the recovery room unit is not necessary. Blood also should be sent for measurement of hematocrit, serum electrolytes, blood sugar, PT-PTT, and platelet count. After lower extremity revascularization, patients should remain under intense observation for at least 6 to 12 hours. Similar laboratory evaluation should be accomplished. It is during this immediate post-operative period that most early graft occlusions occur. Hourly checks of pedal pulses with Doppler signal confirmation should be made. The absence or diminution of Doppler flow should prompt rapid assessment by the vascular team. Early bypass occlusion often results in acute severe ischemia due to the loss of collateral flow from surgical dissection, clot propagation distally, and dependence on the bypass for limb perfusion. Prompt heparinization and graft thrombectomy revision is necessary for limb salvage in these instances. Now, most patients are prescribed antiplatelet therapy, usually aspirin, which in femoropopliteal grafts with good outflow is appropriate. DVT prophylaxis with either low molecular weight or unfractionated heparin is ordered until the patient is ambulatory. We occasionally will use low-dose intravenous heparin, 3 to 500 units per hour, in addition to aspirin for the first 24 to 48 hours after surgery for complex or prolonged tibial reconstructions, or those requiring intraoperative revision. Long-term anticoagulation in combination with low-dose aspirin is sometimes used for below-knee reconstructions using synthetic grafts or marginal quality vein grafts. However, there are no conclusive data that anticoagulant is superior to antiplatelet therapy for graft maintenance post-operatively, and combined therapy increases risk of any bleeding in the long term. Pain management is a key component to early ambulation, pulmonary care, and gastrointestinal function. Epidural anesthesia that provides analgesia for 2 to 4 days after abdominal operations is an excellent but controversial method. Standard narcotic-based therapy is also used. As to antibiotics, antibiotics is generally continued for 24 hours post-operatively unless otherwise indicated. But generally, the recommendation is for you and for us to follow our institutional IDC protocols with regard to antibiotic prophylaxis for our patients.